It's my great pleasure to introduce our next speaker, Dr. Michael Klompus. He is our main hospital epidemiologist at Brigham and Women's Hospital, so he's been a little busy the last few months. He is also a professor of population medicine and a member of the infectious diseases division at Brigham and Women's Hospital, and he's going to talk to us today about pneumonia in hospitalized patients. Thank you so much for joining us.
No worries. Thank you very much for the opportunity to speak to you. I'm trying to visualize all the people out there listening, and I wish we could be together in person to have this conversation more closely, but such is our current times. Let's jump to it and start talking about pneumonia. These are my disclosures. I have grant funding from CDC and royalties from UpToDate for chapters on pneumonia. And these are the topics I hope we can speak about today. How accurate are the clinical signs for pneumonia? Is pneumonia in hospitalized patients more likely to be viral or bacterial? What kind of imaging should we get? Is there a role for procalcitonin? Do we need to get cultures? Do we need to start antibiotics right away? What should we treat with? Do we need to include atypical coverage? And how long should we be treating for? Okay, let's do it. So I want to draw your attention to the fact that the American Thoracic Society updated their guidelines for the treatment and diagnosis of adults with community-acquired pneumonia. This was a long-awaited update from the Thoracic Society and the Infectious Disease Society. The last version of this was published in 2007, so we had to wait for this for over a decade. And so it's a real milestone that we now have this. And as I go through the talk, what I say to you will be consistent with these guidelines. And in a few cases, there are some situations where I have a slightly different take on the evidence. I will clearly designate to you what the IDSA guidelines say versus what I say and why I'm slightly different. So you'll be able to make your own call as to how you'd like to proceed. To get us into the right frame of mind, let's consider this case study. A 68-year-old woman with a history of congestive heart failure and mild dementia is admitted to hospital from a nursing home with confusion. She appears a little bit tachypneic, but denies shortness of breath. She has an intermittent, non-productive cough, but it's not clear whether this is different from baseline. On exam, she is lethargic, but easily arousable. Her temperature is 100, her heart rate is 110, her blood pressure is 108 over 64, and she's breathing 24 breaths per minute. Her oxygen saturation is 90% on ambient air. JVP is difficult to see, and maybe there's some crackles in the bases. She has mild lower extremity edema. Her labs are notable for a white blood cell count of 10.2, her hematocrit is 32, her platelet count is 240, her sodium is 130, creatinine 1.4, and her liver function tests are normal. On urinalysis, there are about 4 to 6 white blood cells per high-power field, and a portable chest X-ray is consistent with edema and possibly a left lower lobe infiltrate. Here is the chest X-ray. Okay. And here's the question for you. Does this patient have pneumonia? So register your answer for yourself. Is that a yes or a no? And I think if you're like me, the honest answer is I'm not too sure, maybe, but not so clear. But when push comes to shove is this. Whether you're sure or not, you have to make a concrete decision. Will you start antibiotics? Yes or no? So think to yourself, what's your answer to this? Yes or no? You can't be on the fence here. You have to make a decision, right? This is real life. So register your decision for yourself, and then let's go through it. So my first question is, why is pneumonia so difficult to diagnose? I mean, this is a condition that we have known about as physicians for literally thousands of years. This is something that was commented upon by early Greek and Roman doctors. And after all this time, how come it still is such a bear for us? And I think the fundamental issue is that many medical conditions in hospitalized patients present with the same clinical signs as pneumonia. So if you think to yourself about the core clinical signs that we looked for to diagnose pneumonia, so radiographic opacity, fever, abnormal white blood cell count, impaired oxygenation, increased pulmonary secretions, it's not going to take you more than a few seconds to come up with a big differential diagnosis for each one of those signs. In other words, lots of things can cause each one of those signs. And I think that's the core problem over here, is that none of these things is either perfectly sensitive and certainly not specific. And that's been well documented. So there are a number of autopsy studies where they looked for the correlation between the clinical signs of pneumonia and the presence or absence of pneumonia on histology. This is my favorite of those. It's a study from Brazil. And they first applied what they called a loose definition, a patient who had an infiltrate and at least 2 of an abnormal temperature, white blood cell count, and particle secretions. And you can see over here that relative to histology, sensitivity around 65%, positive predictive value around 45%. So then these guys said, okay, let's kick it up a notch. What if we apply a strict definition and infiltrate in all 3 of fever, leukocytosis, and parallel secretions? Now again, put yourself on the wards. If you're seeing that patient, you're not hesitating to give that patient antibiotics, right? That seems like a very unambiguous kind of a presentation. But what was the correlation with histology? Check this out. It dropped the sensitivity to below 20% because you're requiring more signs, and those signs are not always present, but barely budged the positive predictive value, meaning that those signs are non-specific, that lots of things can cause that constellation of clinical findings. Now, what about the cultures? You can certainly accept that maybe the signs are not diagnostic, but this is an infection. The microbiology should be diagnostic. So here's the data culled from a number of studies on the sensitivity and positive predictive value of BAL, so bronchoalveolar lavage, quantitative cultures for pneumonia relative to histology. And you can see the results are all over the map. If you pool these things collectively, you get a sensitivity around 65 to 70% and a positive predictive value around 70%. So what's going on over here? I mean, how come the microbiology is not diagnostic? And I think that there are a couple of things going on over here. The sensitivity is imperfect, either because of prior exposure to antibiotics, which we know is common in a hospitalized population, or because with a bronchoalveolar lavage, you fail to sample the exact right section of the lung where the pneumonia lies. So if you sample the left upper lobe and the pneumonia was in the right lower lobe, you're going to miss it. Conversely, the positive predictive value is imperfect because you can pick up colonizers from the oropharynx, or if you're doing a procedure from the lower respiratory tract. So that's why, despite the fact that you would think that the microbiology is diagnostic, it really is not. So next question over here. If the patient does in fact have pneumonia, and again, we're on the fence, is it more likely to be bacterial or viral? Now, there's been a lot of data on this, and if anything, COVID has taught us that a virus is an incredibly potent cause of pneumonia. So I think if ever there was doubt before about the power of a virus to cause a bad pneumonia, that should be put to rest now. But in fact, it's a message we've always known. We've always known that, in fact, even amongst hospitalized patients with pneumonia, that viruses are actually more common than bacteria. Here's the best of these studies done by CDC. This is about 2,250 patients admitted to 5 hospitals from Chicago and Nashville. And these patients were sampled incredibly extensively with a series of serologies and PCRs and cultures and urine antigens. And the 2 big findings are these. Number 1, viruses were more common than bacteria, about twice as common as bacteria. Number 2, despite the fact that they were doing very extensive evaluations of these patients, they were unable to identify a etiology 62% of the time. So 2/3 of the time, they couldn't find any pathogen. Now that bears reflecting upon. I mean, why is that? Is it the phenomenon I was speaking to before about maybe this is imperfect sampling or maybe this is prior antibiotic exposure? I think that's certainly possible. I think the other possible reason is maybe there are bugs out there that we haven't yet been able to identify and don't know how to recover by culture or PCR. That's a possibility. But I would say that based upon our analysis of the limited accuracy of clinical signs relative to histology, I wouldn't be surprised if a good chunk of these patients didn't have pneumonia, right? So despite the fact that they had the label pneumonia, I think those histology studies would teach us that many of them did not. They had mimicking conditions like pulmonary edema or atelectasis or COPD exacerbations, so on and so forth. If you look in terms of the particular viruses isolated, again, this is what you'll see over here. In blue is the viruses, in orange are the bacteria. You can see rhinovirus is number 1, flu number 2, and strep pneumo coming in only at number 3 and only accounting for 5% of the pneumonia population. So really a very small minority, despite sort of our classic association of strep pneumonia as being number 1. It's not number 1, and it's not that common in the current day and age in the context of the additional etiologies of pneumonia, in the context of vaccination, etc. Actually, let me tell you one other thing about this is I want to call your attention as well to the atypicals over here, to Mycoplasma, Legionella, and chlamydia pneumonia, which are present. You can see they certainly appear on this list of top agents, but again, are rare. So mycoplasma pneumonia accounted for 2% of patients with pneumonia, Legionella 1.5%, chlamydia 0.4%. Store that little fact away, because when we start to talk down later on the slide in the presentation about the need for atypical coverage or not, that's going to provide some context for that discussion. Collectively speaking, over here, if you look at the meta-analysis level, the overall prevalence of viruses in community-acquired pneumonia is at least 25%. And in fact, if you look at there are a couple of studies over here that are outliers. Look at this one over here or this one over here. And the reason that they had higher rates of viruses present was because they used lower respiratory tract sampling as opposed to just nasopharyngeal or oropharyngeal PCRs. And that's something that a lesson that's been brought home to us with COVID as well, is that you can increase the sensitivity detection by looking for lower respiratory tract specimens. So I think this tells us that 24% is the minimum prevalence of viruses in pneumonia. It's probably higher. My next question for you is, given our uncertainties around diagnosis and the high prevalence of viruses, when you admit a patient who has pneumonia, do you need to start antibiotics right away? So let's think about this a bit. First of all, if we look at the population of patients who are getting antibiotics for pneumonia against those who are admitted to hospital, and you look at their clinical signs, I was surprised to learn that a good chunk of them have perfectly normal clinical signs. 79% did not have a fever. 82% had a median respiratory rate less than 22. 55% had a white blood cell count in the normal range. 39% had an oxygen saturation above 95% without supplemental oxygen. All told, all these signs were normal in almost 1 out of 5 patients, just about 20%. So that gives you pause. Like, why are these patients being started on pneumonia if everything we can see about them is stone cold normal? And I think this echoes a theme that's been well reported, which is that we overtreat pneumonia. We give too much antibiotics to too many people for too long. And this is one sort of concrete bearing out of that message. And I think that if you put yourself in the boots of the doctors who are probably doing this, I'm guessing the reason was because at the moment, in the heat of the moment, maybe the patient didn't look good, or there was a transient abnormality in their respiratory rate or their white blood cell count, or there was an ambiguous finding on the chest X-ray, or you couldn't tell if the patient was wet versus euvolemic. And so we erred on the side of giving these patients antibiotics. But as the dust settled, it became clear that there was a different diagnosis, or that the worry signs for pneumonia self-resolved with supportive care. And I think that then begs the question, well, what if you had not pulled the trigger right away on pneumonia, but rather wait to see, do these things self-resolve with diuresis, nebulizers, tincture of thyme, etc.? Is it safe to actually wait and see if the patient is going to settle down or not? And so here's some data on that. Now, we know that if a patient is very sick, if they have septic shock, that time really matters. This has been a well-described finding over here, that each hour of delay in a patient with septic shock is associated with increased mortality. So if the patient's very sick, you don't have the luxury of waiting to work out if your diagnosis is correct or not. You just got to treat that patient. However, we are learning from the world of sepsis that in patients without shock, that pattern between delay in antibiotics or time to antibiotics and mortality is much less firm. So this over here is data from New York State looking at their mandatory sepsis reporting and bundle rule. And this was a determination of the association between each hour until antibiotics and in-hospital mortality. This included about 50,000 patients. And what was nice is that they had enough patients able to stratify between those who did have shock, those who got vasopressors, and those who did not. And what you can see over here was that there was a clear association between more time to antibiotics and mortality in those who required vasopressors, but not in those who did not, suggesting that it's a septic shock population, the sickest of patients, where time really matters. So putting this together, what the Infectious Disease Society of America has been saying is you need to approach the decision about timeliness or urgency of antibiotics by taking into account 2 factors. One is, what's your certainty of infection? And number 2 is, how sick is the patient? Now, if the patient is if you're certain about the diagnosis of infection, right, it's unambiguous, you have positive culture data, you have pus sort of coming out of a body site, then it doesn't matter how sick the patient is. The patient requires treatment, right? So in that case, you don't delay it all. You go ahead and treat the patient. However, and likewise, if the patient is very sick, if they have the possibility of septic shock, it doesn't matter how certain you are about the diagnosis. So long as there's a possibility the patient's infected, you don't have the luxury of waiting. You have to treat that patient right away because delay will lead to death. However, if you're in this red zone over here, where you're not so certain if the patient has an infection or not, you're on the fence, and the patient's not so sick, you're more in the infection or mild sepsis range. In those sorts of patients, the guidance would be to hold those antibiotics, get more data, do more diagnostic testing, more imaging, more culturing, wait and see what the results of culture data are to inform that decision as to whether or not to treat that patient, rather than pulling the trigger immediately on antibiotics. And we have some data, it's indirect data, but it is data suggesting that not only is this probably safe, but in fact might even lead to better outcomes for the patient. So this was a study looking at BAL versus sputum cultures for patients with pneumonia. It was a randomized controlled trial. And in the patients who were randomized to get sputum cultures, the protocol required treating the patient if they had anything on gram stain or a positive culture. And so it turned out that everyone who got a sputum culture had a positive gram stain, more or less. About 100% of those patients got immediate antibiotics. Those who were randomized to BAL, only about 50% had a positive gram stain, and therefore only about 50% of those patients got immediate antibiotics. The others, they waited to see if their cultures grew anything or not. Patients who had sepsis, severe sepsis, septic shock, they were treated immediately. So what ended up happening, though, is because of this pattern of gram stains being frequent in those who had sputum cultures and rare in those who had BALs, this turned out to also be a trial of immediate antibiotics versus delayed antibiotics. And you can see that those in the liberal arm, just about all of them got immediate antibiotics, and those in the BAL arm, this more parsimonious arm, only about half got antibiotics. Now, that was associated actually with a decrease in 14-day mortality and a trend towards lower mortality at 28 days, not statistically significant, suggesting that this strategy of, so long as the patient's not critically ill, get more data first and only treat if there's clear evidence of pneumonia, appears to not only be safe, but potentially beneficial. So we're still on the fence about our patient. We still, I think, haven't quite decided if our patient has a CHF exacerbation or a bona fide pneumonia. And so we saw the chest x-ray was difficult to interpret. Could further imaging help? Should we get a CT scan on this patient? So we have data on this. Here's a nice study. This one came out of France, 319 patients evaluated in emergency departments in whom the treating physician, based upon history and an initial chest x-ray, thought the patient might have had pneumonia. And these docs were asked to stratify, to classify, how certain are you about the diagnosis of pneumonia? Definite, probable, or possible. So there are their initial classifications based upon clinical history and the plain chest x-ray. Then they sent all these patients for CT scan, and look what that did to their evaluations. If the coloring changed to orange or one of these two shades of yellow, that meant that the diagnosis became much less certain and in essence was excluded or felt to be unlikely. You can see that amongst those in who the docs beforehand were pretty certain the patient had pneumonia, they classified as a definite pneumonia, the CT scans did not change much. However, if they were on the fence and thought that this is a probable pneumonia or a possible pneumonia, CT scan eliminated up to 50% or more of those cases from being pneumonia. So the take-home message over here is not that you have to CT scan every single patient, but if you're on the fence, it can be a helpful diagnostic adjunct, and most of the time, it's actually going to rule out pneumonia. Here's a summary finding from that study. You can see that with CT scan, it dropped the amount of definites down to less than half the population and was able to exclude pneumonia in almost one half. Here, this is just a warning slide over here, which is that the pattern can go in the other direction as well. It's not simply that the CT scan always rules out pneumonia. Sometimes you can take a patient who at first blush appears to have a normal chest x-ray, and the CT scan can show there is a pneumonia hiding. So one has to exercise some caution in using this the strategy. It can give you diagnostic information for a rule in or a rule out. How about procalcitonin? Could that help us with our diagnostic certainty? So this is an interesting study. This actually comes from the same study I showed you before, looking at 2,250 patients trying to work out the etiology of their pneumonia across 5 US hospitals. And in addition, in that study, they actually checked out procalcitonin levels in all the patients. And they went back and correlated the procalcitonin level with the presence of a virus versus a bacteria. Now, you'll remember the classic teaching is that the procalcitonin is supposed to be high with bacteria and low with a virus. It turns out, as you can see from the study, that things are not quite so clean. Now, certainly there's a pattern that the higher the procalcitonin level, the more bacteria is present and the less virus is present, but there is no cutoff over here where you have exclusively virus with a low procalcitonin or exclusively bacteria with a high procalcitonin. And that's the hint that procalcitonin, while it will give you a general pattern, is not going to be a definitive answer as to whether it's a bacteria or a virus that's causing the patient's presentation. This was further tested in a randomized controlled trial where they took precisely the population, I think, of greatest interest to us, those patients in whom the doc is on the fence. Could be pneumonia, not sure it's pneumonia, not sure it's viral, not sure it's bacterial. Let's get a procalcitonin and see if it helps us or not. So this was 1,656 patients with possible pneumonia randomized to procalcitonin versus routine care. What did they find? Actually had no impact on either antibiotic starts or ultimate duration of antibiotics. And I can think, again, that's consistent with what we saw, was that procalcitonin is an imperfect guide to differentiate. I'm not saying there's no role for procalcitonin at all. I think that as part of many building blocks of information, it could be an additional factor to take into account, but you should not fool yourself into thinking that it's determinative for the diagnosis. Now, should we go ahead and culture for bacteria and test for viruses? So this is what the ATS-IDSA says. They say get a sputum gram stain and culture in an inpatient if any of the following is present. The patient has severe pneumonia, if you believe empiric coverage for MRSA or Pseudomonas is necessary, if the patient has a prior history of MRSA or Pseudomonas, or if the patient has risk factors for resistant pathogens, namely prior hospitalization, or they received IV antibiotics within the preceding 90 days. Sorry about that. Test for influenza if influenza is circulating in the community. So not every patient, just if it's that time of year. By contrast, here's my opinion. I'm more pro-culture, particularly for the inpatient population. And I would personally get a sputum gram stain and culture plus viral studies in all patients who have been admitted for pneumonia. And here are my reasons. That the risk factors for resistant organisms are all ill-defined. And so relying on risk factor analysis as well is going to be wrong a good chunk of the time. If you do get positive cultures, it can help you to tailor your treatment. And if you get negative cultures, that can facilitate stopping antibiotics early. And then on a bigger picture population point of view, culture data is critical to help the hospital generate antibiograms and to inform decision-making around future empiric treatment choices. And then COVID has taught us as well as anything that viruses can be present at any time of the year. And that's true for influenza as well. And they can cause bad pneumonias. So I think there's value in trying to determine if that's a factor in your patient or not. I think it has implications for antibiotic utilization, has implications for infection control, and implications for public health understanding. Now, if we are going to go ahead and treat, what antibiotics should we use? This over here is a table from the ATS-IDSA guidelines over here. I think they're very reasonable. If the patient has mild disease, use a beta-lactam plus a macrolide or a fluoroquinolone. Do you need to add MRSA coverage? Again, in a patient who has mild disease, if the patient has a prior history of respiratory MRSA, then go for it. Note that they're careful to say respiratory MRSA because MRSA is common in skin sites, but less common in pulmonary sites. If there are risk factors alone for MRSA, but the patient has mild disease, you don't need to cover for MRSA up front. Rather, get some diagnostic information, cultures and nasal PCR, and only add on that MRSA coverage if the nasal PCR or culture is positive. Similar approach to using Pseudomonas. Only need to give it up front for the patient with mild disease. If the patient has a history of Pseudomonas, their risk factors, get some diagnostic information, and only treat if the cultures are positive. By contrast, in a patient with severe disease, where again your margin for error is less, their recommendations are a beta-lactam for all patients, and then either a macrolide or a fluoroquinolone. And in this case, they'd say that if you do have risk factors or a prior history of MRSA or Pseudomonas, go ahead and cover for those bugs up front. What's the actual sensitivity, the accuracy of a nasal MRSA culture or PCR? Here's a meta-analysis of 22 studies, about 5,000 patients. Sensitivity turns out to be around 85% positive predictive value. It's 57% negative predictive value, 98%. In other words, this is good for excluding MRSA, but not so good for being certain that it's present or not. So if you have a negative nasal MRSA culture, you can feel that much better about withholding MRSA coverage for that patient. Now, how about this question of atypicals? Do we need to give every single patient coverage for atypicals? You'll see that the ATS IDSA guidelines said yes. Let's dig into some of the data and see how strong that supporting data is. So number one over here is a randomized controlled trial. It's a cluster randomized controlled trial, around 2,250 patients hospitalized with CAP, but not severe, non-ICU in the Netherlands. And they were randomized to a beta-lactam alone, a beta-lactam plus a macrolide, or a beta-lactam plus a quinolone. You can see over here in 90-day mortality, there was no difference at all. Okay, so at the macro level, it seems like it does not make a difference to use a macrolide or a quinolone in an undifferentiated patient. If you know the patient has Legionella or mycoplasma, of course you want to treat it. If the patient has a clinical picture that's very concerning for that, they're immunocompromised, multilobar disease, low sodium, etc., clues that the patient might have an atypical pneumonia, I think you'll want to be more upfront. But at a macro level across the entire population of pneumonia patients, we're not seeing a signal. Now, you might be saying to yourself, 90-day mortality is a very coarse window. Can we get some finer clinical read on this on these different treatment regimens? So here we have median hospital length of stay. No difference, exactly the same in all three arms. Okay, so the hospital length of stay is certainly a better read, more granular read as to how well patients do. Can we get even more granular than that? So here's another randomized controlled trial. This one done in Switzerland, 580 patients randomized to beta-lactam alone versus beta-lactam plus a macrolide. Now, actually, cast your eye first to the right-hand side of this graph. ICU admissions, 30-day mortality, 90-day mortality, no difference. And that's actually then consistent with the prior study. However, if you look on this more granular level of clinical stability on hospital day 7, defined using an array of physiologic markers, there was a trend to a little bit more instability in the beta-lactam alone arm. So not statistically significant, but a sort of a question mark. And more interestingly, there was actually more readmissions in patients who had beta-lactams alone compared to those who also got a macrolide. So we have this hint that maybe in a subpopulation of patients that the macrolide or quinolone for atypical coverage might add some value in getting the patient better faster and maybe decreasing readmissions, but nothing seen at the macro level around 30-day mortality or 9-day mortality or hospital length of stay. Now, helpfully, in this study, they stratified the results by severity of illness. So here's patients with mild illness, here's moderate to severe illness. Black is beta-lactam alone, red is beta-lactam plus macrolide. In those with mild illness, no difference. It was only in the population of patients with moderate to severe illness that you could see a small coming apart of the two lines. And this is, again, looking at time to clinical stability. And only in that clinical parameter can you see a bit of a difference. The take-home message for me is that you probably do not need to use atypical coverage in every single patient with community-acquired pneumonia, but really reserve it for those who have more severe disease or those who are at risk for very bad outcomes, the immunocompromised population in particular. How about aspiration? What does aspiration, do all those patients require antibiotics? So a couple of studies on this. Here's one. This is a retrospective analysis of patients with aspiration pneumonitis, and they looked at those who got antibiotics versus those who did not. Now, the groups were similar in demographics, comorbidities, and risk factors, and antibiotic treatment was associated with no difference in mortality, no difference in ICU transfers, and in fact, once you start antibiotics, you are more likely to escalate antibiotics, suggesting that you get yourself into a cycle of treatment once you decide to treat. And so the take-home message from this study was that all else being equal, aspiration alone does not routinely require antibiotics. And again, personally, I would say you look at the clinical signs of the patient. If the patient is manifesting sustained signs of severe illness, tachypnea, decreased oxygen saturation, hypotension, those would be my triggers towards prescribing. How long should we treat for? So here is, I think, the ultimate study. I think it's one of the most influential randomized controlled trials in inpatient medicine ever. And this was a comparison of 8 versus 15 days of antibiotic treatment for ventilator-associated pneumonia. And this was a study done in France, about 400 patients. They randomized to 8 versus 15 days. The message over here was there was no difference in outcomes, no difference in all-cause mortality, vent-free days, organ failure-free days, ICU length of stay. There were slightly more recurrent pneumonias in those who had Pseudomonas and other non-fermenting gram negatives. But when they looked at clinical outcomes, even for the pseudomonal patients, they were identical whether they got 8 days or 15 days. And that's why both the US and the European guidelines now say that for ventilator-associated pneumonia, hospital-acquired pneumonia, 7 days is the default duration of treatment. How about in CAP? Can we get down to less than 8 days? So here's a randomized trial of 5 days versus 10 days for community-acquired pneumonia, 312 patients in Spain. And you can see over here that the 5-day regimen in red compared to the 10-day regimen in yellow associated with identical clinical success rates at day 10 and at day 30. They did a subgroup analysis looking at patients with more severe disease, so port scores of 4 or 5, same thing. No difference in clinical outcomes with 5 days versus 10 days, and that's why 5 days is the default duration of treatment for community-acquired pneumonia. But is less than 5 days feasible? How low can we go? So there are actually a couple of randomized trials on this, at least 2, looking at 3 days versus 8 days. So 3 days of treatment versus 8 days of amoxicillin, trial done in the Netherlands over here. You can see identical clinical cure rates, bacteriological success rates, and radiologic success rates. Here's another randomized trial, 3 days versus 8 days, same message over here. Clinical cure rates identical with 3 days versus 8 days. So that kind of begs the question, do we need any antibiotics at all? Don't worry, the answer does appear to be yes. So here we go. 3 days versus 0 days for community-acquired pneumonia. This is a pediatric study. I'm sorry I couldn't find an adult equivalent, but I do think it's important to establish that antibiotics do still have a role, despite all that we've seen so far. And those who are randomized to 3 days of amoxicillin versus placebo, those who got amoxicillin had about a 50% decrease in their odds of treatment failure on day 3, and slightly less relapse and adverse events. So don't worry, you still need to use antibiotics for some pneumonias. Could procalcitonin help? Now, we saw that procalcitonin was not helpful in that initial decision as to whether to treat or not. It did not give us a definitive answer. It was not associated with a difference in antibiotic utilization. But how about for determining duration of treatment when we can stop antibiotics safely? Is procalcitonin more valuable in that setting? So we do have good data on this. There are a couple of high-quality randomized controlled trials looking at patients with sepsis in particular. This is, I think, the biggest and the best of those. This is about 1,600 critically ill patients randomized to daily procalcitonin checks versus routine care. You can see those who got daily procalcitonins, they were able to shave about 3 days off the average duration of antibiotic treatment for those individuals. And that was associated with no difference in ICU length of stay, and in fact, a lower mortality rate in those who are randomized to procalcitonin, so suggesting that the strategy is safe. They kindly provided a subgroup analysis for those who did have community-acquired pneumonia. It's a good chunk of patients still, about 440 of them. And again, these are ICU patients, so this is severe pneumonia. Those in the procalcitonin arm got a median of 5.5 days compared to those in the procalcitonin got a median of 5.5 days versus 7 days in the control arm. But if you look at the interquartile range over here for the procalcitonin arm, the 25th percentile was at 3, meaning that 25% of those procalcitonin patients were treated for less than or equal to 3 days, and their outcomes, as with the total study, were just as good as those who got longer durations of treatment. So the take-home message appears to be that procalcitonin, yes, it can be a helpful adjunct to decreasing duration of treatment. So here's what the guidelines say. The ATS-IDSA guideline does not allow for much nuance here. They say treat all patients with community-acquired pneumonia for a minimum of 5 days. My personal opinion is slightly different. I'd say if the patient is immunocompetent, hemodynamically stable, clearly improving, then I think that less than 5 days is fine. And I say that is because we've seen that the diagnosis of pneumonia is often questionable, when present is often viral. And then we have at least 2 randomized controlled trials showing that 3 days is as good as 8 days for both mild and severe community-acquired pneumonia. So I think you can get by with less, but again, being open over here, the guidelines say 5. Finally, how many days of antibiotics does a patient need after discharge? Here's a very nice study from Michigan quantifying this across almost 6,500 patients from 43 hospitals. And what you can see over the graph over here is the duration of treatment in the discharge prescription. How many days of antibiotics were written to the discharge script over here? You can see that about 15% got 0 days, a couple percent got 1 day, 2 days, so on and so forth. What's striking about this is you can see a big chunk of patients over here got 5, 6, 7, 8, 9, or 10 days. Now, and it was 5 days was in fact the most common duration of treatment at discharge. And of course, if we say that 5 days, even taking the generous ATS-IDSA approach, is the standard duration of treatment, in essence, what that seems to be saying was that the doctors were resetting the clock at discharge. So they were not giving the patients credit for the days of antibiotics they got as inpatients. And that clearly is exceeding the guidelines. And in fact, they said that this then led to overtreatment of 68% of the population, and it was the discharge antibiotics, not the inpatient antibiotics, that accounted for the vast majority of unnecessary antibiotic days. And they showed this was possibly associated with harm. Each additional day of treatment was associated with a 5% increase in the risk of adverse events. So here's my summary. Diagnosing pneumonia is very challenging. We're often wrong. CT, though, might give you more diagnostic clarity if you're on the fence. Many, if not most, pneumonias are caused by viruses, therefore test for them and adapt your treatment accordingly. Tailor the urgency of treatment to the severity of illness and your certainty of infection. If you're on the fence and the patient is stable, get more data before you start antibiotics. Know your local antibiogram to inform your antibiotic choices. Vancomycin is not necessary for most patients. And if you start it, stop it if MRSA cultures are negative. Atypical coverage is most important for patients with severe disease or a compromised immune system. Short course regimens of 3 to 5 days are usually adequate. Serial procalcitonin measures might help you to get to a shorter course, and don't reset the clock at discharge. Okay, thank you.
All right. Thank you so much for a great review of pneumonia. We have a lot of questions, so I'm just going to start in. So the one that floats to the top right now is pneumonia treatment for patients with QTC prolongation. Should we give macrolides versus fluoroquinolones or get a cardiologist opinion?
Okay, good question. So I think a couple of parameters you want to take into account. The first question is, does a patient need antibiotics at all? So we've seen that if the patient has mild disease and the diagnosis is uncertain, that you might actually want to see, can you acquire more diagnostic clarity first? CT scan, clinical observation, cultures, viral testing, so on and so forth, because maybe you don't need to treat that patient at all. Number 2, does the patient actually have any evidence of an atypical infection? We saw that atypicals actually only account for about 2% of the pneumonia population, and so in most cases not present. And I think it was clear that the population that benefits from atypical coverage are those with more severe disease. So if you talk about a patient who has mild pneumonia and you don't have particular a clinical syndrome particularly suggestive of a atypical disease, the patient's not immunocompromised, you're not seeing sort of bilateral infiltrates, you have normal sodium, you get a urine Legionella, and that's negative. Again, I think I would not give anything at all. If you do need to treat, I think that you're probably better off using a quinolone compared to a macrolide, but I would track the QT syndrome, try to stop other QT prolonging medications, and just keep a close eye on the patient.
All right, there are a few on a theme, which is about diagnostics. So one of the questions is asking about, my questions just moved. Should you have a sputum sample collected by a respiratory therapist or just expectorated? And then there's another question about the use of, like, should you actually just use a PCR respiratory panel versus getting a culture? And then sort of the last thing linked on this is what viral studies should you check? So what sort of diagnostics do you suggest, and do you think that a respiratory therapist should be involved in collecting those?
Yeah, no, great questions. So I think definitely the quality of the specimen is going to be very important. If you're just going to get spit in a cup over there, that's not going to be a very good representation, or might be taking place inside the lungs itself. Do you need a respiratory therapist to get a high quality specimen? I mean, not necessarily. I think it depends on who you are working with and what the patient's sort of capacities are. You could very well collect a decent sputum specimen yourself and sort of being there at the bedside and make sure the patient gives a good quality cough and look at the specimen itself. And then once the laboratory reads the specimen and they comment upon the amount of epithelial cells, that give you some sense to whether you got a decent specimen or not. So I think you want to judge that based upon the patient, your capacity to collect the specimen, your nurse's capacity to collect the specimen, and you can decide for yourself, based upon your own local practice situation, who needs to do so. In terms of of diagnostic panels, so the world is definitely moving towards more use of rapid diagnostics, particularly PCR-based and its alternatives, and I think they're very promising. I think that there are lots of data showing that they have good yield, so reasonable correspondence with what you might get from culture. What we don't yet have is very clear evidence showing that it impacts outcomes, both in terms of total duration of antibiotic utilization or length of stay and mortality. I think we all intuit that they probably should, and that with better quality studies we might see that signal, but we don't have a very robust signal yet. I think the only thing you're really losing out on by doing the sort of rapid diagnostics is that only a fraction of them will provide antibiotic susceptibility information. And so you'll get more clarity as to what the pathogen might be, but if it's a bacteria, less clarity as to what kind of treatment might be necessary. So ideally, if you want to partner with your lab to see that if they are doing rapid diagnostic panels, that they choose some of those that do offer some susceptibility information as well. In terms of viruses, classically speaking, many hospitals only tested for influenza. And I think that's partly was a function of what was available in terms of testing, and partly a function of the fact that we have treatments for influenza and less so for the other viruses. I think what's become clear, though, is that influenza only accounts for a minority of viruses that can cause hospitalizations for pneumonia, and therefore it's a very limited slice of the picture. And I would argue for a hospitalized patient, there is value to looking at the other potential viruses as well, partly because of infection control reasons. You don't want that patient sharing a room with another patient, because nosocomial respiratory viral infections is a recognized problem. And number two, it's going to influence your antibiotic treatment. Now, it's not quite so simple as saying that just because you get a positive virus that you automatically stop all antibiotics, right? Because co-infection is a possibility. But certainly it can be a factor to take into account about the necessity of antibiotics to integrate that with your culture information and your read of the patient's clinical course. So I think that there's high value to testing for a fuller array of respiratory viruses. Which ones in particular? As you alluded to, there are panels out there that already come with a stack of them, and that's totally fine. You can go with the pre-existing stack. At a minimum, I would include COVID, of course, in this day and age. I think it has to be part of it. Influenza, RSV, parainfluenza, adenovirus, metapneumovirus, and what am I forgetting? Rhinovirus. That would be I think that would account for the majority of potential viral pathogens. Okay.
Well, thank you so much for a great review of pneumonia.